Only mode. Hi everyone, it's Fiona at AAMAC. We're just going to give it a few more minutes for others to join before we get started.
I'm getting quite a loud squeak. Is that you, Fiona?
No, I'm not really doing anything. I'm not sure what's causing that.
What is going on with the sound?
Sounds like the microphone is picking up every little sound.
Yeah. So do you get an echo, or is it just me?
I wouldn't say it's an echo. It sounds a bit like you're, in a room.
Okay.
A little bit.
Because I'm getting a delay, and then what I said comes back to me, but I'm already saying something else. So it might get a little bit confusing.
Well, after the introduction, I'll mute my line and see if that makes any
sense. Oh, maybe. Yeah, that might make a difference. We're up to 6.
Yeah, give it another minute or two. Okay, well, I guess we'll get started. Hi to everyone who's joined us on the line. My name is Fiona Lewis, and I'm pleased to welcome you to this webinar hosted by AAMAC. AAMAC is a leading funder of research into bone marrow failure disease in Canada, and our organization supports patients and caregivers across the country who are living with aplastic anemia, myelodysplastic syndrome, and PNH. I'm the patient support liaison for BC and Alberta, and I invite you to visit our website to find out more about our services across the country. So I'm pleased to introduce our speaker for today's webinar regarding the latest research on myelodysplasia. Dr. Heather Leitch is the Director of Hematology Oncology Research at St. Paul's Hospital. She completed a PhD in microbiology at UBC in 1992. She graduated from medical school at UBC in 1994 and completed a hematology fellowship at McGill University in 2000. She completed post-fellowship training with the lymphoma tumor group at the BC Cancer Agency in 2002 and currently holds the position of clinical associate professor at UBC. Dr. Leitch has been a member of the Hematology Oncology group at St. Paul's Hospital since 2004 and actively participates in research projects and clinical trials with a focus on hematological malignancies. Recent publications co-authored by Dr. Leitch have focused on the treatment of iron overload in patients with myelodysplastic syndromes and other acquired bone marrow failure syndromes, HIV-associated lymphoma, and relapsed myeloma, MDS, and lymphoma. So we're going to have time for questions at the end of Dr. Leitch's presentation. I invite you to type any questions you have into the chat window on the right of the screen, and I will then read them out for Dr. Leitch to answer. And if we have time to, we may unmute the lines so that people can just ask her their question. So with that, I will turn it over to her to begin her presentation, and I will mute my line. So Dr. Leitch.
Thank you, Fiona. So I was asked to talk about the latest research on MDS, which is actually quite convenient for me because what I did was I modified a talk that I just gave at the satellite session to the European Hematology Association. So, you know, pleasure to be here and to share this with you. I don't think you really need to see my disclosures. This is the general outline, so introducing MDS, which is no surprise to any of you. And then, you know, I'll spend most of the time talking about management of anemia in MDS, complications, transfusion burden, the benefit of reducing transfusions, new approaches to reducing transfusions, and then we'll talk about a case study in management of iron overload, some conclusions and future directions, and I will say a few words on higher risk MDS and newer treatments coming at the end. So again, no surprise to you, MDS is a heterogeneous group of clonal bone marrow failure syndromes that is characterized by ineffective hematopoiesis and the potential for progression to acute leukemia. And we have several prognostic scores to predict survival and AML progression. One I haven't listed here was actually developed from the Canadian MDS patient registry and incorporates patient-related factors such as comorbidities and disability into the prognosis. These other scores actually just consider disease MDS-related characteristics. But that's a topic for another day. So of course we need to, you know, classify and risk stratify in order to come up with the appropriate treatment, which includes documentation of how many of the cell lines are low, what the morphologic abnormalities are, the marrow blast count, the chromosome abnormalities, and now we have access to molecular abnormalities in many cases. And we generally divide patients into lower and higher risk to determine management. So this is kind of a basic overview of lower risk and higher risk. This is by several prognostic scores. And so generally low or intermediate 1 IPSS or an IPSS revised score of less than or equal to 4.5. These actually scores are more frequently used in Europe than in North America. Some of the WHO classifications, so single lineage dysplasia with ring sideroblasts, isolated del5q, and some of the molecular abnormalities, for example, SF3B1, which is generally found in subtypes with ring sideroblasts, have a better prognosis. And so other, you know, so the opposite of that for higher risk, any MDS with excess blasts, and some of the molecular abnormalities, and ones that examples I've included here are the TP53 and the ASXL1. And so we'll be hearing much more about some of these and other molecular abnormalities as we go forward. And in fact, there's an international working group working on incorporating molecular abnormalities into the IPSS-R, so it's called the IPSS-RM for molecular. So you'll be hearing about that in the future. So turning to anemia, It's really a hallmark of MDS. It can be challenging to manage, and most patients eventually require red cell transfusions. And so, you know, sort of signs and symptoms of anemia: shortness of breath, weakness, skin pallor, fatigue, hypotension, lightheadedness. It can exacerbate cardiovascular complications, and for those of you who are anemic, you will recognize that it very much impacts on quality of life. So we do look at therapeutic options by the risk score. For lower risk MDS, we have the erythropoiesis stimulating agents such as EPO and darbepoetin, lenalidomide, which is generally used in del(5q) MDS, immunosuppressive therapy, which we don't use that often. Hypomethylating agents are generally used in higher risk MDS, but in selected cases can be used in lower risk MDS, and of course everybody gets supportive care, which includes transfusions, iron chelation, platelet transfusions, and growth factors where needed. So this is just another way of showing the treatment options for del(5q) and sort of in a flowchart kind of way, and I'm not going to belabor that. Just a very nice kind of flowchart by Dr. Platzbecker from Germany. We do know that transfusion dependency, which I think is a very cute European word, transfusion dependence in lower risk MDS is associated with inferior overall survival. So the effect is more noticeable in patients with lower risk MDS and is associated with the severity of transfusion requirement. So here we have survival, and the top curve is people needing 0 units of red blood cells every 4 weeks, and then 1, 2, 3, and 4, and you can see that stepwise decrease in survival. And this is leukemia-free survival on the right in lower risk MDS patients. And this is classic data from Dr. Malkavadi from 2006. On the right, we see more recent data from the European LeukemiaNet MDS registry, and so what it's showing is, I can't see all of my screen because of the function things on top of it. I think I actually, oh here, I have a hide, there we go. So this is patients with no transfusions on the top, low transfusion density, which was defined as less than 0.87 red cell units per month, which is an odd cutoff, but for technical reasons, and high transfusion density, so you see that decrease in survival. And now my slides aren't advancing. Here we go. Okay, we also have data that MDS patients who are transfusion dependent and then become transfusion independent have reduced mortality compared to patients who remain transfusion dependent. So this was a systematic review and meta-analysis looking at overall survival, and included were studies that recruited adults with MDS and reported overall survival for transfusion independent versus transfusion dependent patients. And they looked at 89 articles with 55 separate data sets, and the analysis showed consistent survival benefit in transfusion independent patients that was associated with a 59% reduction in risk of death, and there's the hazard ratio and significant credible intervals. And the overall survival benefit was independent of MDS severity. And so iron overload, as many of you know, is an interest of mine. This is a consequence of red cell transfusions. This is just a diagram showing that iron overload is also impacted by absorption from the GI tract. So we have macrophages of the reticuloendothelial system. We have a hepatocyte here. I don't know if you can see my pointer, but an enterocyte from the intestine on the right. And so what happens is that iron is absorbed in the GI tract and is transported across the basolateral membrane into the bloodstream by ferroportin. But if the liver secretes hepcidin, which is hepatic means liver, and hepcidin is a molecule that comes from the liver, what that does is it downregulates ferroportin, and so it actually decreases the iron uptake in the GI tract and release from the macrophages. Erythroferrone, which was more recently discovered and is produced by erythroblasts during maturation of red blood cells, has a negative feedback on hepcidin, so that will reverse these effects and cause an increased GI uptake. However, having said that, that's for the science nerds in the crowd. Having said that, the main way that we get too much iron is from transfusions, and these are the organs that are impacted from transfusion dependence. So people with a moderate transfusion requirement of 2 units per month will accumulate 100 units over 4 years, which is 20 grams of iron, which is too much. And this is deposited in the tissues and organs and causes toxicity, but also results in the presence of oxidative stress, which is due to the ability of iron to transfer electrons, which I think I talk about a little bit more in the future. So patients with ring sideroblasts subtypes may be more likely to develop iron overload for a couple of reasons. So compared to other MDS subtypes, the hepcidin levels are the lowest in patients with ring sideroblasts, so that will stimulate GI absorption of iron. So we frequently see patients with ring sideroblast subtypes presenting with a high ferritin level, a measure of the iron stores, without having received any transfusions. And also, RARS patients have been shown to have the highest levels of non-transferrin bound iron, which is one of the indications of oxidative stress. But patients with ring sideroblast subtype have a relatively long survival, so there's more time for transfusional iron overload to accumulate to toxic levels. And iron overload has been associated with increasing morbidity and exacerbation of pre-existing comorbidities and impaired survival, as I'll show you. So this is an analysis from our group. And it shows that patients with ring sideroblast subtypes receiving iron chelation therapy had superior survival to those not receiving iron chelation therapy. And this was done as a consequence of other investigators suggesting that maybe ring sideroblast patients don't benefit from iron chelation therapy, but in our experience, they do. So there's many measures of iron overload, and I'm not going to go through these in any detail. One of the simplest way is to keep track of transfusions, and it's actually, I find it very helpful when my patients keep a journal of their transfusions. It's sometimes difficult for us to follow because what we'll get from the blood bank is what was cross-matched, which wasn't necessarily what was transfused, and some people are transfused in other jurisdictions from where we are as well, and so we don't have those records. Ferritin level is, the most convenient measure, but sort of inexact because it's influenced by other things. This should say transferrin saturation. So high transferrin saturation is an indication of the presence of oxidative stress. This SQUID is superconducting quantum interference device, which is a fancy imaging way of measuring iron. We have types of MRI, such as the T2-star MRI that we use here to measure iron in the organs. We used to do liver biopsies, which is not ideal in patients who have thrombocytopenia and also neutropenia. We can measure non-transferrin bound iron and label plasma iron, but this is a research tool, as is serum hepcidin levels. So historically, the importance of iron overload management in MDS has been controversial. We did do an analysis from the Canadian MDS registry, which controlled for 4 measures of patient performance status and evaluated survival from time of first transfusion dependence. So there were a number of retrospective analyses, and ours was the first, showing superior survival in patients receiving iron chelation therapy, but survival was measured from the date of MDS diagnosis, because that's the date we had retrospectively, as with all the other retrospective analyses. And one of the potential sources of bias is that maybe people were selecting patients with a better performance status in order to receive iron chelation therapy because they were the ones that might benefit. But in this analysis, we had all those measures of performance status, and the patients were evenly distributed between groups, and it did show superior survival in patients receiving iron chelation therapy. And then we did several matched pair analysis, matching for characteristics thought to affect prognosis, and that supported these findings. So this is all patients, and you can see with iron chelation therapy did better than without. And this is a matched pair analysis, and again, there was a significant separation of the curves. We do have results from the randomized controlled trial of deferasrox, one of the iron chelators, versus placebo that was recently reported. However, it was no longer powered to detect the primary endpoint because of slow, enrollment, because of the controversy surrounding iron regulation. The enrollment was reduced by 2/3, and half the placebo patients withdrew from the study and subsequently received iron chelation. The mean age of the study patients was 10 to 15 years younger than most MDS patients, but despite all these, there was a significant difference in event-free survival in patients receiving iron chelation compared to those who were not. So I think that these data are important and might indicate, because of all these drawbacks to the trial, that it might underestimate an impact of iron overload reduction. Well, some of you may know that iron chelation isn't always easy to administer, and we would like to have other ways to reduce transfusion dependence. So one of the newer medications that's coming, and we expect Health Canada approval for this in MDS in early 2021, is Luspatercept, which is an erythroid maturation agent, or EMA, for treatment of anemia and lower risk MDS. And it's a TGF-beta superfamily ligand binder. And so we have the activin domain up top and the immunoglobulin FC domain in the bottom. And the way it works is we usually get these ligands binding to this activin receptor and sending signals to the nucleus that results in signal transduction and transcription of various genes. But if we block this binding, that then blocks the signal transduction, and that's why we get maturation. So here we have a maturation block at one of the immature red blood cell stages of maturation. But if we block this block with Luspatercept, that's a double negative, which allows erythropoiesis to proceed. And again, I'm not going to go through all these details, but there was a randomized controlled trial of Luspatercept in patients with ring sideroblast subtype, lower risk MDS. And what they showed, and they were measuring responses in terms of transfusion independence for at least 8 weeks, at least 12 weeks, at least 12 weeks for a longer period of time, at least 16 weeks, and so on. And you can see in the blue bars that the responses in the Luspatercept group were consistently higher than those in the placebo group. And on the right, this shows the overall improvement with Luspatercept compared to placebo. And you might think, well, 8 weeks isn't a very long time to achieve transfusion independence, but when you actually look at the detailed data, many patients had many 8-week periods during which they became transfusion independent that lasted for a couple of years, so it was very clinically significant, and I think they also have quality of life data that they're working on. This is an abstract that was presented at the European Hematology Association meeting this year, which was virtual, as you probably know, because everything's virtual these days. And what they did was they looked at ferritin levels in patients treated with Luspatercept or placebo in the MEDALIST trial, and they found that the ferritin decreased, which they thought was due to a direct effect of the drug on ineffective erythropoiesis or on iron metabolism. And overall, the use of iron chelation therapy was reduced with Luspatercept. And they actually found that the magnitude of ferritin reduction, SF is serum ferritin, was similar to that seen in the 1-year EPIC study of deferasrox or iron chelation. So again, quite significant. We now have the ongoing COMMAND study, which is the same treatment, Luspatercept, but in patients with non-ring sideroblast subtypes of MDS. Other new treatments that are coming, this is the ALK5 inhibitor galunisertib in lower IPSS-R risk MDS. And so how this works is we do have overactive signaling of the tumor growth factor beta, or TGF-beta, in MDS. And this is an oral medication that inhibits the TGF-beta receptor type kinase, or ALK5, which I'll show you in a minute. Oh, I'll show you now. So we have that same diagram of the activin receptor and so on. And so here is where it, at this big arrow, is where it inhibits. So this is the ALK domain, and it inhibits that and prevents the transduction to the nucleus. And so earlier trials with galunisertib have shown good erythroid improvement with significant reductions in fatigue and reasonable median response durations and an acceptable safety profile. And so a phase 3 trial has completed enrollment, and we're expecting reporting of that pretty soon. This is the eMERGE trial of imetelstat, or GRN163L, in transfusion-dependent IPSS lower risk MDS relapsed or refractory to erythropoiesis stimulating agents. And so this is a 13-mer, I'm going to explain what this means, 13-mer lipid conjugated oligonucleotide that targets the RNA template of human telomerase and competitively inhibits the enzymatic activity. So our chromosomes, at the ends of the chromosomes, we have telomeres. And with cell division, those telomeres progressively reduce over time and need to be sort of, replenished in order to allow the cells to continue to proliferate. And this is one of the problems in various cancer cells, is that there's an over replacement of the telomeres in the cancer cells. And so here we have this H-TERT is the part of the telomerase, and we have several medications, including imetelstat, inhibiting this so that it can't replenish those telomeres in the MDS cells. And so there were earlier phase trials showing good efficacy in MDS patients, and it's now in a phase 3 trial enrolling patients and randomizing 2-to-1 between active treatment and placebo. And this one is an IV medication given over 2 hours every 4 weeks. And their primary endpoint, like in the Luspatercept trials, is red cell transfusion independence of at least 8 weeks. And is, choosing 8 weeks basically speaks to, the way the response criteria are defined. That's all very complicated and sort of mind-boggling, and that's why they've chosen 8 weeks. And so I won't get into that in any detail, but just in case you're wondering. This is FG4592 in lower risk MDS. It's also called roxadustat. It's an orally administered HIF prolyl hydroxylase inhibitor to treat anemia and MDS and chronic kidney disease, and I'll explain what that means. It does increase endogenous EPO levels by stabilizing HIF, or hypoxia-inducible factor, and also improves iron regulation by modulating hepcidin levels. And so here we have the HIF alpha, and you can see these prolyl groups on it with hydroxyl groups, the OH, attached to them. And here we have the HIF prolyl hydroxylase, and under normal conditions, this binds, and then we get degradation of the HIF. So in MDS, or with low oxygen tension, we get blockage of this binding, and that allows the HIF alpha to go to the nucleus and activate transcription of various genes. So in preclinical models, roxadustat improves hemoglobin level. It is in a phase 3 randomized controlled trial for treatment in lower risk ESA naive MDS with low transfusion burden, and we're actually going to be opening that trial at St. Paul's. Other treatments for low risk MDS, as I mentioned, hypomethylating agents for a minority, lenalidomide for a minority, spliceosome inhibitors will be coming soon to those for those who involve abnormalities of spliceosomes such as ring sideroblasts. We also have another upcoming trial of treatment in lower risk MDS, which is an inhibitor of protein arginine methyltransferase, or PRMT5. This is for patients who are relapsed refractory to ES treatment or who have an endogenous serum EPO level greater than 500. It is an oral agent. It's given once daily for 14 days out of a 3-week cycle. And, just by comparison, Luspatercept, which I talked about a minute ago, which is also oral, can be either for ESA naive or relapse refractory to ESA. So we have something coming up for both groups of patients. Just turning to iron overload for a couple of minutes. So this is a patient of mine. He was 56 years old when I met him. He presented with fatigue. Physical exam was normal. These are his counts. Ferritin was 800, which is above the normal range already. Transfusion saturation was 70%. EPO level was 168, which becomes important in using ESA. Smear showed macrocytosis, and his bone marrow aspect shows increased cellularity, 1% blast, erythroid dysplasia, and ring sideroblasts. Normal cytogenetics, so the diagnosis was at that time refractory anemia with ring sideroblasts, now what's referred to as MDS with ring sideroblasts, and he was IPSS low risk. He was requiring 2 units every 3 weeks. So I've taken this from my iron algorithm, which is now online. The first question is he eligible for agents that induce a transfusion independence? Yes, he's eligible for erythropoiesis stimulating agents. Why ESA? Because the other choices are not, he's not eligible for. Lenalidomide is not approved in Canada for normal karyotype. He lived remotely, so immunosuppressive therapy would have been difficult to administer. Azacitidine was not approved for lower risk MDS in Canada. Stem cell transplant was considered but deferred because of the good prognosis MDS, and he had no sibling donor. Iron chelation therapy is an option, but we prefer to use active treatment, and I'm doing the quote thing with my fingers because I actually personally consider iron chelation to be an active treatment because it does result in hematologic improvement in some patients. And we could consider phlebotomy with a reasonable hemoglobin response to reduce iron overload, and we always consider clinical trials when they're available. So if we go to the MDS ClearPath, which is an online algorithm which we're in the process of updating, the treatment recommendations for patients with symptomatic anemia with EPO less than 500, remember his was 168, we consider treatment with a erythropoiesis stimulating agent, and the I is an information panel. So this gives us the dosing and monitoring with links to treatment information, safety, efficacy, reimbursement, and so on. And this is just to show you that we did do Canadian guidelines for management of iron overload in MDS. And so for those of you who like reading scientific papers, this is very in-depth, and these were published in 2018 by Leukemia Research. This is our online algorithm, the MDS Iron Load, and that's where I've taken these slides from. This is the overall iron algorithm. So low risk MDS, we always assess for eligibility for allo-stem cell transplant. Are they transfusion dependent, reasonable life expectancy? Do they have documented iron overload? The first thing we do is we ask if they are eligible for medications that induce transfusion independence with MDS treatment. And if yes, it takes us to information on phlebotomy. If no, it takes us to information on chelation. So this is what we call the iron load mode. The step-by-step questions we call the IR Express. And you can see over here, we need to monitor iron status, and also we have levels of evidence and grades of recommendations, future directions, and the references. So induced transfusion independence with MDS treatment. Yes. Okay. So this panel says, is he eligible? And so in this case, we click on he received a therapy that can induce transfusion independence. If we had clicked on the yes, it would have taken us outside this algorithm to the MDS ClearPath for information on EPO and DARGO. And so this question is, did he achieve transfusion independence with a reasonable hemoglobin? Yes, he did. And so going back to the case, he needed EPO 60,000 units weekly. His hemoglobin went to about 115. Ferritin was over 1,000 at this point. Transferrin saturation was over 81%, which we know with transferrin saturation over 80%, we find the presence of non-transferrin bound iron or oxidative stress. So here's where I could have started serial phlebotomies, but I was early in my practice at that time and hadn't figured that out yet. So a year later, though, he remained transfusion independent with a very much improved quality of life, as I'm sure those of you who've received ESA and responded to it will recognize. But his ferritin did start to come down over time, and he actually was transfusion independent for 6 years, so that was great. But then he presented with exacerbation of anemia. We did a repeat bone marrow biopsy because we want to know if he's progressed to higher risk, but he was stable. He did develop a regular transfusion requirement, 2 units every 4 weeks, ferritin increase, transferrin saturation increase. So we go back here. Is he eligible for therapy that induces transfusion independence? At this point, no, because ESA is basically all we had. And so that takes us to information on chelation. So he was started on deferoxarox, the dispersible formulation, which was the one that was available at the time. His creatinine promptly tripled, so that wasn't good. So we stopped the deferoxarox, and his creatinine dropped, not quite to normal, but almost to normal. So he started on deferoxamine, which is the infusional one that's given by continuous infusion under the skin for at least 12 hours per day. However, his routine audiology or hearing tests 2 years later showed severe sensorineural hearing loss, which can be a side effect of this medication. So we stopped that medication and wanted to have something to reduce his transfusion requirement and iron load. So we got lenalidomide off-label compassionately from the company that makes it, Celgene, now BMS. He unfortunately developed sepsis requiring an ICU admission. And while he was waiting for Luspatercept, he started deferriprone, again, off-label use. Unfortunately, he developed arthralgias requiring narcotic medications. They were so severe, so deferriprone was stopped actually by his GP. It turns out several months later that he had pseudogout related to iron overload. I did manage to finally, after arguing many times with his private insurer, with the regulatory authorities and so on, I was able to get him a supply of L-trombopeg, which actually has very strong iron chelating activities. Unfortunately, in his second month of treatment, he died of congestive heart failure and infections, which were both from iron overload at the age of 70, which of course is far too young. So it's great for you guys that we have newer treatments coming. I wanted to talk for a moment about cardiac events in MDS. So we know that there's cardiac remodeling with a lower hemoglobin level. This is from Esther Oliva, who's in Italy. And what this shows is that cardiac events are the leading cause of non-leukemic death in MDS patients. And so MDS and AML is the black slice of this pie, and cardiac events are the second leading cause, so are the leading cause of non-leukemic deaths. So we actually looked at our episodes of coronary artery disease, congestive heart failure, and arrhythmia in our MDS patients with lower risk MDS during their period of transfusion dependence only. And we found that the median time to first cardiac event was shorter in those not receiving iron chelation therapy, which was maintained in a multivariate analysis, which controls for other factors that may affect the results. And there is a very nice detailed discussion on the contribution of iron overload to atherosclerosis or coronary artery disease by Francesca Vinci. This is our curve, and so the patients not receiving iron chelation therapy had a shorter time to their first cardiac event than the patients receiving iron chelation therapy. And we also looked at infections in our transfusion-dependent low-risk MDS patients during their period of transfusion dependence. And so why infections? An iron-rich environment enhances the growth of microorganisms, bacteria, viruses, fungi. Iron overload also leads to functional impairment of neutrophils, macrophages, and natural killer cells, all of which protect against infections. We also know in stem cell transplant for hematologic malignancies that iron overload, indicated by several different things, including elevated pre-transplant serum ferritin level, hepcidin levels, or liver iron concentration, is a risk factor for significant infections. And in an analysis from the U.S. Medicare registry, they saw that transfusion-dependent MDS patients had a higher rate of infections than those that were transfusion-independent. So in our patients with lower IPSS risk MDS, the median time to first infection in patients not receiving iron chelation therapy was shorter than those receiving chelation. Here's the curve. Again, faster to time of infection in those not receiving iron chelation than those receiving chelation. And this was despite having similar neutrophil counts between groups, also having similar numbers of infections, similar types of infections, and similar numbers of severe infections, which we defined as requiring hospitalization. You can see the separation of these curves. So this is preclinical data on the left, showing that this is colony formation of erythroid forming cells. And so it's actually reduced. So normal ferritin level is the gray, increased ferritin level is the red, and you can see a reduction in the number of colonies. And then on the right, we have hematologic responses in the EPIC study, which is shown in several different studies, but I've chosen to show you the EPIC. And so they used strict response criteria and found that 22% of their patients had erythroid improvement, with 13 having platelet improvement and 22% having neutrophil improvement. And that's what I was talking about when I said that I think iron chelation is an active therapy. So to conclude this portion, transfusion independence is associated with superior overall survival and quality of life in low-risk MDS. Following failure of erythropoiesis-stimulating agents, the treatment options have to date been limited. Transfusion dependence leads to iron overload, which is associated with inferior clinical endpoints. The number of chelators we have access to is limited. And as you saw from my case example, certainly by no means does everyone have such a rocky course with their chelators, but the use of chelators can be limited by side effects. In future, we'll hopefully have access to more therapeutic options to modify disease course in MDS and induce transfusion independence, and this should optimize both survival and quality of life. And wherever possible, iron overload should be delayed, minimized, or reversed using novel agents with or without phlebotomy. When this is not possible, reducing iron overload with chelation should be considered. So just taking you back to this, I think I showed you this in June, but the log on, so if you put into your browser, I'm not sure if it's the browser, it's the top thing, not into the Google thing, that won't take you to it, but the top thing, if you put in https ://mdsironroad.org, it will take you to the login page. The username is Iron Road without spaces, and the password is Make Iron Great again without spaces. You don't have to go to it. It's really for healthcare professionals, but some of you might be interested. So this is actually a review that I finally finished working on this summer, and it's been submitted for publication. I had a brilliant undergraduate student. I've been trying to get this done since 2014, but thanks to COVID, we're all grounded, and I actually got to nail my butt to a chair and finish this. And so it's called Iron Overload Induced Oxidative Stress and Myelodysplastic Syndromes and its Cellular Sequelae. And it illustrates the activity of reactive oxygen species on cardiac cells, liver cells, and hematopoietic stem cells. And so here we have MDS pathophysiology, which is a little bit complex, but we have altered bone marrow microenvironment. We know from preclinical data that reactive oxygen species disrupt receptors on mesenchymal stromal cells that are important for stem cell maintenance. So here we have the ROS. We also know that ROS alter T cell subsets, so that immune reaction. It activates the NLRP3 inflammasome, which leads to key features of MDS. It also causes stem cells to exit the quiescent state via a shift to aerobic metabolism from anaerobic metabolism, which leaves them, which allows them to remain in a quiescent state. We know that radiation induces ROS, chemicals induce ROS, and we also know that we get from ROS oxidized bases, double-strand breaks in DNA, and error-prone DNA repair. And so that's kind of one of our figures. Again, for those of you who are cell biology inclined, there are detailed figures in this paper about how this affects the cardiac cells, the liver cells, and the stem cells. And I promised to say a few words on high-risk MDS. So we are opening the trial of MBG, which is a TIM-3 inhibitor, which stands for T-cell immunoglobulin mucin domain containing 3, which is a negative regulator of T cells, which speaks to the immune checkpoint you may have heard of. TIM-3 positive stem cells from patients with MDS do display aberrant differentiation, increased proliferation, decreased cell death. And TIM-3 is overexpressed on these stem cells, the MDS stem cells, and increases as the MDS progresses. So blockade of this immune checkpoint makes sense. And this is a high affinity antibody that recognizes TIM-3, and it can be safely administered with hypomethylating agents such as azacitidine in MDS and AML. And we have observed clinical activity in high and very high risk MDS. So this is the trial we're opening, randomizing patients 2-to-1 between MBG and placebo in conjunction with azacitidine. So everyone gets active treatment. It's just a matter of do they get the TIM-3 as well. What I haven't put in this presentation is a number of other agents that are being trialed in MDS. And the reason I haven't, in higher risk MDS, the reason I haven't done that is I do remember clearly sitting through an entire session 2 years ago at the American Society of Hematology of agents that were being trialed in higher risk MDS that were all negative. So I don't want to count my chickens before they hatch. But I'm sure this is not going to be the trade name, but I did advise the company that makes the TIM-3 inhibitor to call this the Timinator. So that's really the end of my talk, and I'm happy to take any questions. I'm just going to reopen my control panel. Interesting, Fiona, I got the echo back when I opened the control panel.
Oh, well, I just turned my microphone on here. So
oh, okay, maybe that's it.
Well, thanks for that information-packed presentation. I'll just unmute the lines. There aren't too many on, so it should be manageable, and see if anybody has a question they'd like to ask. While they're thinking about that, I just comment that it seems like it's a really active time for research for MDS. Would you say there's more happening now than there has been in the past?
I think there's more happening now that's promising than it has been in the past. You know, I kind of think of this as an analogy to aggressive lymphoma. So, you know, back in the 1970s with an aggressive lymphoma called diffuse large B-cell lymphoma, really all we had was single agent cyclophosphamide to treat patients, and there were very few cures. In the 1980s, we developed the anthracyclines, another kind of chemotherapy, and started to see cures with that. And then, you know, in the early 2000s, we got the antibody rituximab, which was added and improved overall survival. And so, you know, I kind of think of treatment of higher risk MDS anyways as where we were at in the 1970s with aggressive lymphoma. So right now what we've got is single agent azacitidine, but now we're starting to add on additional agents, and so hopefully we'll start to see better responses and hopefully long-lasting responses as well, and you know, maybe even the C word cure.
And would you say that most hematologists across Canada would be aware of all this latest research that you presented, or do MDS patients need to educate their own hematologists about what things they've heard about?
Yeah, I think that's a great question. I think it kind of depends where people are practicing and what their kind of main interest is. You know, my main interest, as you know, is MDS and iron overload. So I go to the meetings and the advisory boards and stuff like that and do hear about these things. Certainly people who work in our group and in the city are aware of these things, because I'm going to be emailing them, asking them to look for patients who might be interested in the clinical trials. You know, and I think that's true in most major centers across Canada, because we do have this Canadian MDS working group that contributes to the MDS registry. In smaller centers, I think it's harder to stay on top of what's happening in MDS and in many other disorders. For example, I was talking to a colleague the other day who treats not only blood disorders but also solid tumors as well. So you can imagine that's a lot to keep up on. So, you know, this is one of the reasons that we did develop the MDS ClearPath, and also one of the reasons that we're updating it now, because, you know, to make it accessible to physicians who are, you know, not as able to go to the meetings and the advisory boards and stuff. Now, none of us are able to go to the meetings, but we can at least attend virtually. So that was, and that was also the intent behind the MDS Iron Road. I think that iron overload management does lag behind in MDS because I think in Western countries there's a disconnect between people who treat the benign hematology, so the kids with the inherited anemia such as thalassemia, and people who treat malignant hematology. So during my training, you know, I was always interested in malignant hematology, but I heard exactly not one word about iron overload in MDS, and so it's my generation of hematologists who are training the next generation, and so I wanted to have something easily accessible to people online so that they don't have to, you know, reinvent the wheel.
Mm-hmm. They look like great resources for physicians.
Thank you. I know that even some of our resident trainees are actually using these to study for their internal medicine exams, so, and also some of the pharmacists and nurses are using it as well.
Oh, great. And anybody else have a question they want to ask?
I think I stunned them into silence.
You can also type a question into the question section.
Hopefully, did I go too fast, or was that understandable for you guys?
It was, it's Fiona, it was a little fast for me, but I don't live with these conditions, so, you know, I'm not as familiar with all the terminology probably as patients themselves are.
Right.
But we have recorded the webinar too, so that gives people a chance to listen again. And will you be able to share your slides so we could post them on the website?
Yes, I can.
Okay.
I'll probably have to take out this slide that's not published yet of the oxidative stress review.
Okay.
But I think everything else can go in that.
Okay, that would be great if you could send that to us. So I don't see any more questions. You did mention that it's good for people to keep their own records of their transfusions. So I'll just mention, for those who prefer paper, AAMAC does make available a booklet called the Patient Tracker that allows people to track all their numbers and treatments. So if anybody on the line wants access to that, you can just contact our office and we'll send you one. And we usually produce new ones each year for the coming calendar year. So we hopefully will have those available soon for 2021.
Great.
So yeah, with that, then I'll just thank you again, Dr. Leitch, for setting aside some time to share this information with us. And I invite everybody to continue to look at our website for news of upcoming webinars. We're going to be hosting, we hope, about 5 more between now and Christmas. So because we're unable to do the in-person meetings right now, we're just trying to provide as many webinars as we can for people. So keep an eye on our website.
Yeah, great. Thanks for inviting me. And I'll just say, everyone lie low and stay safe.
Yeah, absolutely. Thank you very much. Enjoy the rest of your weekend.
Thanks.
Bye-bye.
Bye.